Muchas gracias a la doctora Riley. Para seguir con este interesante módulo de cáncer de páncreas, que como ustedes saben va en un franco aumento en la incidencia, yo soy el doctor Carlos Chan del Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán. Y bueno, es obvia la necesidad de un tratamiento multidisciplinario, dado el carácter sistémico de esta enfermedad. Y es clara también la necesidad de un tratamiento quirúrgico, que es la base para tratar a estos pacientes con tratamiento sistémico, con quimioterapia y otras alternativas. Sin embargo, la secuencia óptima de tratamiento es lo que es todavía un debate, es una pregunta esencial, si dar quimioterapia neoadyuvante, después la cirugía o cirugía y después el tratamiento adyuvante. Y para discutir esto ya escuchamos la parte pues de la cirugía, de tratamiento neoadyuvante, y ahora el doctor Peter Allen de la Universidad de Duke en Carolina del Norte, quien es jefe de cirugía oncológica y un gran experto en cirugía pancreática y con múltiples publicaciones al respecto, nos hablará de la parte contraria de la cirugía primero con quimioterapia adyuvante. Doctor Allen.
I love Dr. O'Reilly. I worked with her for many years, and she is just so terribly wrong on this topic. It is all about patient selection. All of these trials are. We think prospective randomized trials represent the whole population of patients. They do not. And we all know this, that these trials all are very well selected patients. And I'm going to dig into a little bit about the data, and then actually about the practical aspects of delivering care to these very challenging patients, and some of the problems we can get into when we just want to do neoadjuvant therapy in everybody, as Dr. O'Reilly so clearly stated. So, pancreatic cancer is a horrible disease. It's an incurable disease, even in patients who present with the smallest of tumors. And the best long-term outcomes are found in patients who receive both high-quality complete resection, operation, and effective systemic therapy. That's where we are. She's absolutely right about that. That is where we see our best long-term outcomes. And we know that there is benefit with both resection and systemic therapy. I'm not going to dig into the question of radiation therapy, but data are present that support both. This is a study that if you have not read this trial, you should read this trial. It did not get a lot of publicity, but it was a trial performed in Japan where they took patients with resectable pancreas cancer to the operating room and did a laparotomy and explored them to prove that they were resectable. And then they randomized them to whether or not they were actually going to do the resection versus treat them with chemoradiation. So they closed the patients who randomized to chemoradiation and treated them with chemoradiation after they'd proved they were resectable. Very small trial. The 5FU was the systemic therapy. Primary outcome was mean survival, and this is their long-term results, which showed that surgery alone in a randomized group of patients with truly resectable patients had improved survival to patients who received chemoradiation, a study we would never be able to do in the United States. Their quality of life was similar, and let me tell you, when we talk about hospital cost, and in the U.S., we are starting to talk about cost more and more, and the cost of chemoradiation was more than what was received in the surgery alone group. So there is benefit to surgical resection in patients with resectable pancreas cancer. There's also benefit with systemic therapy. This is a systemic disease. This is the CONCO-1 trial, randomized patients to gemcitabine alone versus nothing after resection. These are the results, clearly showed significant improvement in both disease-free survival and overall survival. Dr. O'Reilly glossed over this trial, and she said that the results were encouraging. This trial showed the single best outcome ever in patients treated with pancreas cancer with adjuvant FOLFIRINOX. This trial is spectacular. This isn't improving median survival by a couple days. Look at the survival in these patients with who received adjuvant FOLFIRINOX. Median survival, 5 years. 5 years median survival. We have never seen survival outcomes like that in any study. The Dutch trial she showed, PREOPANC-1, which claims to have put in resectable patients, median survival in their good group was 17 months. I mean, come on. We should abandon neoadjuvant therapy because of that study. So we know that long-term outcomes are found in patients who receive both resection and effective systemic therapy, and our argument is around who should go first. So Dr. O'Reilly would argue neoadjuvant therapy ensures that all patients receive some systemic therapy, however, some won't be resected. And not only because of disease-related outcomes. I argue surgery first ensures all patients who can undergo resection will be resected, and some may not receive systemic therapy. So the arguments for neoadjuvant, and I would say the primary is it will, number one is that biology argument that some of those patients who are destined to fail early won't go to the operating room. We've spared them an operation. I would argue with FOLFIRINOX, that's no longer the case. There was a small study published out of Indiana which looked at resectable patients who were treated with FOLFIRINOX before an operation, and none of those patients progressed while they're on FOLFIRINOX. They all went to the operating room for resection. So it wasn't a selection help. And so many patients don't receive adjuvant therapy. And I've watched this over the years. This has been an argument that after an operation, these patients are just so sick, they don't receive adjuvant therapy. And it dawned on me when I was down in North Carolina, where we have very sick, obese patients with comorbidities like heart disease, kidney failure, diabetes, long-standing vascular disease. They've smoked their whole life. These are not the patients that walk into Memorial Sloan Kettering Cancer Center in Manhattan, New York. These are sick patients. These patients can't receive neoadjuvant therapy either. They can't receive effective neoadjuvant therapy. They can receive neoadjuvant gem, but neoadjuvant FOLFIRINOX, that's a heavy lift too. Those patients are also selected patients. So this group of patients who don't receive adjuvant therapy oftentimes wouldn't receive neoadjuvant therapy. And there are a group of patients who are sick, who are taken to the operating room, who are not prepared for effective systemic therapy. So let me throw in some pragmatic concerns I have about neoadjuvant therapy for all, which is what Dr. O'Reilly was arguing. This is a patient who came to see me just when I showed up at Duke. 70-year-old healthy patient, came in with weight loss, slightly increased bilirubin. CAT scan showed a dilated bile duct, a mass in the head of the pancreas, an elevated CA19-9, and so he went to the gastroenterologist where he had an EUS performed. The FNA did not show cancer, which is a common finding, correct? So he's had a procedure that costs about $20,000. They didn't put a stent in because he was not particularly jaundiced. I don't know why they didn't do that. And because it was November, and the holidays, he really didn't get seen back until January. So now, almost 2 months after he presented, the scan revealed persistent dilation of the bile duct. He underwent an FNA of the pancreas. He had a stent placed, initially showed atypical cells, chronic pancreatitis. He was reviewed by our center, which confirmed cancer. He ended up having post-stent pancreatitis, admitted to the hospital, and finally referred to the surgeon. Now, 3 months after he presented with a resectable tumor in the head of his pancreas, having had probably $100,000 worth of healthcare costs being delivered to him. And now, we did do neoadjuvant chemotherapy because the pancreatitis was so bad from the stent and the biopsy, he couldn't have an operation. And he was a fit patient. Operation was performed. He did eventually do well, but just think about that cost that was put into the system for a patient who received an operation and chemotherapy like we would like to do. This is another patient who I saw, actually the very first day I showed up in North Carolina. I was called with this patient, 67-year-old bilirubin of 37. This was her scan. This is her tumor, little tiny tumor sitting there. And they called me and asked, what should we do? And the gastroenterologists were lined up to do their procedure, to put in a stent, to do a biopsy. And on August 26th, this was Friday, I think this was Monday, we did a Whipple procedure. And then, probably 3 or 4 weeks later, she was on to adjuvant FOLFIRINOX. So let's just look at the cost and the complications that are introduced with preoperative therapy. So I would just say practically, when we talk about employing this on a all-comers basis, we need to be careful about some of these additional procedures that in a patient who presents with a resectable tumor in their pancreas are unnecessary. Unnecessary for preoperative biopsy, unnecessary for EUS, unnecessary for stenting. These procedures that oftentimes we have to repeat because we don't get the diagnosis. We have to repeat because they put in a plastic stent and that just got clogged. Lots of costs, lots of morbidity. So I would say that all of these considerations, a preoperative biopsy plus an EUS plus a stent equals time, money, and risk. And I think these are things we have to consider, particularly when we have data such as the PRODIGE trial that's showing adjuvant FOLFIRINOX results in median survivals of almost 5 years. These are the NCCN guidelines for patients who present with a pancreatic mass. Biopsy not necessary. The only thing I would throw in here as a little bit of a caveat from a surgical standpoint is autoimmune pancreatitis, that person with a resectable mass in the pancreas, we need to be careful to check for this. But I think if this is done, then a biopsy is not necessary to proceed to the operating room for resection. Elevated IgG4, a serum test can be done to diagnose this, and those patients would be treated with steroids rather than resection. Now, Dr. O'Reilly's going to come up here in a minute and say, these stents, they're not a big deal. They don't cause much in the way of problems. Well, these are prospective randomized data from the Dutch. The Dutch love to do prospective randomized surgical trials, and this is published in the New England Journal of Medicine, which clearly shows that just the placement of that stent increases our complications of the operation significantly. These are the complications in patients who went to the operation early versus the patients who had preoperative stenting. Stenting is a significant problem. If we could get our hands on these patients before they have been scoped, ERCP'd, stented, biopsied, these patients who have small resectable pancreas cancers, I think a trial in that setting would clearly show, if you look at cost and you look at outcome, that preoperative neoadjuvant therapy may not be worth it. So routine biliary drainage is not warranted. there are patients in which it should be considered. The patient who I operated on had a bilirubin of 37, but she was a fit patient. Operating on fit patients with very high bilirubins is safe as long as those patients have preoperative IV hydration. Prolonged time assessment, comorbidities, variant arterial anatomy. These are some situations where stents could be helpful, but they shouldn't be considered routine. So I would simply say, from a pragmatic standpoint, given that we don't have prospective randomized data that clearly show an improvement in survival in patients who have neoadjuvant therapy, what would you do? What would you do? 72-year-old healthy male, weight loss, bilirubin of 15, CA19-9 here, and a small resectable mass in the head of the pancreas. What would you do? Would you recommend an ERCP and stent placement, and EUS and biopsy, and if diagnostic, recommend neoadjuvant therapy once the bilirubin normalizes and hope that they don't get post-procedure pancreatitis and don't develop stent occlusion on treatment? Don't forget to ask them for that metal stent up front. Would that be your answer? Or would you just proceed with a Whipple and then give them fulferinox in a few weeks? I mean, this is a simple argument. And so what I would say is that since I won this debate, I would say that Dr. O'Reilly actually is correct, as she always is, in that at this point, tailoring the recommendation to the individual and the tumor is the best way, I think, for us to proceed. There are patients who I think, and will probably continue to think, even after 5 or 10 years from now when these additional randomized trials are done, that upfront resection makes sense. A fit patient, straightforward resection, low to moderate 19-9, no tissue diagnosis when you see them, immediate access to the operating room, very high bilirubin where it's going to take a long time for that to normalize. I think those patients we would typically lean towards upfront resection. Neoadjuvant therapy, certainly patients where you're concerned that they might not be able to, if they're going to get fulferinox, the only time they're going to get it is before the operation. I think those patients should be considered for neoadjuvant therapy. Large tumors, high 19-9. The patient who walks into our office, who has a tissue diagnosis, their bilirubin's down to normal, they have a stent in place, they can start systemic therapy right away. I think those patients make sense to start with neoadjuvant therapy. So I guess in reality, we go back and forth as to who goes first. And I think even with the planned neoadjuvant trials that are occurring, that Dr. O'Reilly is correct, that as long as patients receive both fulferinox and resection, patients with small resectable pancreas cancers, we believe we'll be providing them the best possible outcomes. Thank you.